Cancer remains a major health challenge for women worldwide, with breast, cervical, ovarian, and lung cancers among the most prevalent. This International Women's Day, Voice of Healthcare in collaboration with Zydus Life Sciences presents SheLeads, featuring women in cancer care, a virtual campaign honoring women in leadership in oncology care to drive awareness and early detection. Join me in welcoming our esteemed panel of women leaders in oncology whose expertise and dedication are transforming cancer care. Dr. Tanvi Sood, Senior Consultant Medical Oncologist, Paras Healthcare, Gurugram. Welcome, Dr. Tanvi. Dr. Akanksha Chhabra, Consultant Medical Oncologist, DMCH Cancer Care Center, AOI Precision Cancer Care, Punjab. Welcome, Dr. Akanksha.
Thank
Dr.
you.
Vaishnavi Joshi, Consultant Medical Oncology, Haemato-Oncology, and Stem Cell Transplant, Aster CMI, Bangalore. She would be joining us shortly. Dr. Namrata Udupa, Senior Consultant Medical Oncologist, Nanjappa Life Care, Shivamoga, Karnataka. She would also be joining. Dr. Nandini Menon, Professor Medical Oncologist, Tata Memorial Hospital, Mumbai. Welcome, Dr. Nandini. Dr. Asma Pathan, Consultant Medical Oncologist, MOC Cancer Care and Research Center, Pune. Welcome, Dr. Asma.
Well, thank you. Good morning.
Dimple Parmar, Founder and CEO, Zen Onco. Welcome, Dimple.
Thank you. Happy to be here. Happy to see to all of you.
So I'm Dr. Manisha Khurana, your host for the day. And my first question goes to Dr. Tanvi. Despite growing awareness, many women still present stage cancers. What are the biggest barriers to early detection and how can we overcome them?
That's a lovely question to begin with. Biggest barriers, there are so many in today's date. And if you want to speak even women specific, awareness still stands to be one of the biggest barriers. Lack of awareness. If the, mind does not know, the eyes don't see. So there's really a need for awareness programs and public platforms like these, to at least bring out certain points like if there is a breast lump, what could it mean? At what age does it mean? It could be malignant, when to get checked, and so on and so forth. But there are so many other barriers, like everyday problems women face that are related to deep fear and taboos related to these, diseases. So still breast and ovarian cancers or even cervical cancers, breast lump or pervaginal bleeding, these are all related to private parts. So at least this is what we encounter in OPD. Many women, when they come to us with an advanced stage, we ask them, you must have noticed the swelling. So they're always shy, they withhold, and the family members, they tell us very painfully, nobody expressed us, they didn't tell us, they didn't share it with us. There is still a lot of fear, there is still a lot of taboo, it cannot happen to me, these kind of things. And also to highlight, women tend to have vague symptoms. So women are used to tiredness, women are used to a higher pain threshold, so to speak. Must be age related, must be because I had a tiring day, tired from the household work, tired from the routine work, office work, looking after children. So women tend to look after themselves last. I think everyone can identify with this. And many times we notice that those early symptoms, subtle symptoms like tiredness, weakness, weight loss, these things tend to get missed amongst women. So, I mean, that's how I would like to highlight awareness and lack of self care leads to these problems.
Yeah. So we don't care ourselves. That's what I believe. And fear is a most important factor. So Dimple, can you tell me that we have been talking about certain barriers, so psychosocial barriers that often deter women for seeking medical help, and what are the most effective way to address them, and these fears and the stigma around cancer screening? I can't hear you, Dimple. Unmute yourself.
Yeah. So I want to clear one distance where cancer is a lot more. and people don't come for screening or don't come even after when they are diagnosed with cancer. I believe community education programs led by survivors and healthcare professionals can be a good beginning. And also addressing the issue such as cancer is not ultimate death sentence. Rather, it is something which we can use as empowerment and early cure for cancer. So instead of taking fear-based approach, if it is empower-based approach, then it can really help people and culturally also sensitize them towards it. And because in tier two, usually people associate cancer with death, family burden, social isolation. Also, when we are doing the screening and focusing on this early detection, if we can integrate mental health support or pairing this with counseling approach, so that women feel safe in talking about it and share their ongoing challenges, and also peer support groups can really be helpful here. And when we are doing such camps or such awareness, using women leaders, local influencers, and survivors can be a very trustful medium to pass this message, because they tend to believe more in their local leaders. And instead of making it a big thing around screening, if we can do it in a very different way of maybe in the community centers or providing it free or low cost, can break those stigma and make it more apprehensions to the screening and early detection for women.
Right. So camps are really important. I believe that we have been laying stress on cervical cancer screening as well. So my next question would be to Dr. Akanksha. Routine screening like mammograms and pap smears are key to early detection. Yet again, the adherence, remains low. What strategies can be implemented to improve compliance, especially in underserved communities?
Very rightly said that pap smear and mammographies, they are important for, they are key to early detection, and which is very important for us because it leads to good cure rates. Compliance is an issue. So to combat this issue, I think the best method is to go for, the patient should come in direct contact with the physician or the cancer specialist via the healthcare camps or the outreach strategies. So when the patient comes in direct contact with a doctor, he or she understands why this test is being recommended, what are the pros and cons, and what we can do to put it in an effective way. Also, this helps to increase the patient education, increase the cancer awareness in such women, because these women, they neglect their own health status. So this is one point. Another point is when we do health camps, most of the health camps, they're free of cost. So it also helps to reduce the financial burden. So I think the healthcare camps and the outreach strategies are the best method for the compliance.
Right. And we have been talking about pap smears and molecular testing. So I would like to ask Dr. Vaishnavi that genomic profiling, liquid biopsy, molecular testing, they are the emerging tools for early cancer detection. How can these be integrated into routine clinical practice for better outcomes?
Hello, good morning to everyone. So this liquid biopsy testing and genomic profiling has been there in the last 5 years to 10 years or so in detection of in the prognostication and cancer treatment monitoring. But now, yes, it is being used in early detection of cancer. We have quite a lot of commercially available kits to do liquid biopsies which detect circulating tumor cells or ctDNAs to find out if this particular person has any of these cells circulating and could be a harbinger or underlying cancer, to detect underlying cancer. But then there is a lot more work to be done in this scenario because there are many scientific and ethical issues involved in this. We have some commercial kits which detect these CTCs, and then a screen positive person has to undergo imaging and then tissue biopsy to prove the cancer is there. And also we can detect what is the origin of these cancer cells also in these patients or this population. But then if there are any false positives, it could for if there are false negatives, for example, if the tumor is not a very shedding kind of cancer where CTCs and ctDNAs are not shed into the circulation, so that can be a false reassurance. Or
I think there's some network issue, Dr. Vaishnavi. So I would like to ask Dr. Nandini that We have seen that AI is, coming up in big way, especially in diagnostic industry, and digital pathology is also there. So, how do you think they are transforming cancer detection, and how do you see these technologies evolving to aid oncologists in clinical decision making? Unmute yourself, Dr. Nandini.
Sorry. So I think in today's era, we have to accept that AI is going to be a part of diagnostics in the future. So digital pathology itself just means that you kind of digitalize, or it can be just like scanning slides and having images for a pathologist to interpret. But AI goes beyond that, looking at not just trying to replicate the human the analysis and the neural pattern. So it can be machine learning, which the computer program can be trained to take in large amount of data and come up with the patterns and signals that a single human brain cannot. And it also can go beyond that to deep learning, so trying to look for patterns amongst, like in slides, or in even including patient related data excluding pathology, trying to see patterns which cannot be seen by a single or a few people, because large amounts of data needs to be analyzed. And definitely now with digital pathology, for us oncologists, two things. One is looking at slides, be looking at automating simple things like scoring for certain patterns, for example Gleason scores, or breast cancer, looking at biomarkers and scoring for HER2, or maybe that can be done by an AI machine. And then but then you also need to understand that once AI gives you an output, probably we need at this point of time still a human to confirm and verify if it is right. But AI can evolve beyond that, including looking for morphological features in thousands of slides, and then coming up with patterns to predict, probably without doing additional testing, what kind of tumor, what kind of driver it might have. So I think it has already happened in radiology, where looking at radiological scans may give us indicators to whether this is a driver mutated lung cancer versus a non-driver mutated lung cancer. In glial tumors, we all know we heavily, in brain tumors, rely on radiological features to kind of predict, especially when you can't get a biopsy. So for an oncologist and pathologist, especially in this field, AI is going to give a lot of information in the future regarding not just the diagnosis, the likely prognosis, and probably a predictive indicator to as to what treatments the patient will develop. Now, a lot of these things are still being validated and they are not commercially available, but that is going to be there. And there are also other AI tools, not just for pathology or radiology. There are tools like IBM Watson, where they look at patient-related data and they may guide you what would be the best course of action, what option of treatment to choose. So I think AI is going to really help us in the future, provided we know how to use it correctly.
Right. So AI is assisting us. It needs to be validated by human, but definitely it is helping us in clinical decision making. Very well said. So my next question goes to Dr. Asma. Many women hesitate to seek medical attention due to fear of diagnosis. We have been talking about it. So how can we reshape the communication around cancer screening to encourage proactive healthcare seeking behavior?
Hello.
Yes, Dr. Asma. We can hear you, but
Yeah.
I can't see you.
Regarding reshaping communication around cancer care, it should be like there should be shift from fear-based communication towards a early detection, empowerment, and a positive healthcare outcome. So that should be our aim, like shifting it from the fear, uh, like like we changing the narrative. When we change the narrative of the program, like screening helps to save life. Telling this way instead of telling early screening can prevent death. So we have to reshape the narratives. The second one is we have to make these screening programs very easily accessible to the patient, just as said by Dimple. We have to make it accessible to the ladies either through communities or with the healthcare setups which give free screening services. And other thing will be like it should be like less like patients are more anxious when they go for screening camps. They have a fear that they'll be diagnosed with cancer, so we have to give them that less anxious way of handling going through screening procedures. And many of the ladies have that fear for screening because it is painful. I'll be diagnosed with disease. So we have to make awareness regarding these programs with the help of social media, with the help of healthcare workers or some different platforms using community leaders making community programs so that women are known about these screening programs and how they can access it easily, and so that the early detection comes into picture and the outcomes are better. So this way we can address these issues, and all community people, community leaders, and even the social media platform makes lot of differences, making this communication easier. As we are doing this program will help ladies to understand what are these cancer related issues, how can they come out without any problem and solve their issues.
Right. Right. So communication is the key. But once diagnosed, I would like to ask Dimple that how do you manage, as someone who has worked closely with patients, what non-medical interventions such as mental health support, lifestyle changes have you seen making biggest impact on recovery and resilience?
Right. So we have seen with integrative oncology, which is combining medical treatment with complementary care, we can definitely manage their side effects, improve quality of life, and extend life wherever it's possible. Some of the therapies include mind-body therapies like yoga, meditation, and breathing exercises like pranayama that has significantly improved treatment tolerance, pain management, and stress levels. Nutrition, gut health plays important role. So plant-rich diet with anti-inflammatory diet reduces recurrence risk as well, and it also enhances chemotherapy effects. Gut microbiome research shows that dietary modification can enhance treatment response to their immune systems. Combining that with emotional healing and counseling, we have seen that patients who address their trauma, their shock, their unresolved emotions, they have shown better treatment outcomes and recovery rates. So, psycho-oncology support should be a part of the standardized cancer treatment care. And lastly, Ayurveda and holistic therapies. There is a myth that it cures cancer. Rather, it is to be used only for supportive post chemotherapy healing and immunity care. So during the chemotherapy, it may not be taken, but post chemo, post radiation, it can be taken as a supportive care to manage the side effects. And there are herbs like turmeric, ashwagandha that have shown scientifically significance in cancer management. So if we integrate complementary care well into the medical treatment, definitely we can look at the better outcomes and success rates.
Right. So they complement each other. Right. So Dr. Namrata has joined us. Dr. Namrata, I would like to ask you that primary care physicians often play a crucial role in early referrals. How can oncologists work more effectively with primary care providers to expedite diagnosis?
Good morning, everyone. Yeah, primary care physicians, primary care providers actually play a very crucial role because still cancer is only what we are seeing. The number of cases is only the tip of the iceberg. A lot many cases are go undiagnosed, and because of various reasons, lack of awareness even among the primary care physicians. So some screening camps and educative sessions for the primary care providers is very crucial. And even amongst the alternative medicine community also, the awareness needs to spread. The Ayush people are seeing in the especially in the second and third tier cities and in the villages, they see there are very high volume practitioners seeing about 50 to 100 patients per day, and a lot of cases are going undiagnosed, and they're not coming to us. So collaboration of oncologists with primary care providers is also important, be it awareness camps wise or the educative sessions wise.
Right. So, Dr. Tanvi, how do you see the advancements in targeted therapies and immunotherapies help you approach treatment personalization for women cancer?
So now there is a concept called personalized cancer treatment, which we also call precision oncology, or personalized treatment. That's basically based on the concept that each cancer is different and unique. One person's lung cancer is not the same as another person's lung cancer. There are some specific receptors, proteins that are unique to that person's cancer. And now with the advancement in science, we have learned to learn about these receptors, test for these receptors, For example, some patients, breast cancer patients, they have hormone receptor positivity, some have hormone negativity. These are starting to become very common terms now that people are aware of HER2 positive breast cancers, HER2 negative breast cancers. There are several mutations in lung cancer patients, especially in advanced stages, that we test for mandatorily in all our patients now, whether it's EGFR, ALK, ROS, so on and so forth. All these mutations are now there. So whenever we encounter patients in our OPD, these are the first things that we sensitize it. No, after the primary diagnosis of the patient, we tell them, okay, but this is not just limited to a diagnosis of breast cancer. There is a molecular classification also. There are receptors that we need to test for, and then using these targets, we are able to optimize and personalize the treatment for our patient. So even with the introduction of immunotherapy, there are biomarkers like PDL1 testing, MMR deficiency. These are tests that are now simple tests because they are very widely available, very easily available now at almost all centers. And actually, all patients should undergo these tests because earlier the dictum was conventional therapies like chemotherapy, but now we've learned to use other agents like immunotherapy. These are drugs that enhance our own immunity and unmasks the potential of our own immunity to act against cancer cells, whereas chemotherapy always acted on one shoe fits all sort of an approach, and it does not have a specified targeted way of working. And then there are targeted therapies, biological therapies, many types of immunotherapies, TKI, tablet form therapies, where it's not just injections and chemotherapy. We have even tablet formulations where it's become that much easier for us to offer treatment to our patients, even older patients. And it's all thanks to these targeted therapies, the science of looking for such targets, and precision oncology.
Right. So we have been, talking about personalizing the treatment, but I believe that there are so many myths around, cancer, and it's still prevailing. So, Dimple, can you tell us that what are the biggest myths and misconceptions about cancer that still, persist today, and how can we leverage digital campaigns like this to dispel these myths?
Right. So there are many myths around cancer. As we know, the most important is cancer is equal to death sentence, which is not the case. So early stage cancers have high survival rates, and even metastatic cancer nowadays are managed as chronic disease. So some survivor campaigns of fourth stage survivors can play a big role in this. The second myth is Ayurveda alone can cure cancer. While we know that Ayurveda is a supportive therapy, not a replacement for modern oncology. So probably running some campaigns around integration of both together and how well this integration has played role in terms of the recovery outcomes, and how risky it can be if one only solely rely on Ayurveda. So some digital campaigns around that can really give hope to people in terms of how can we integrate and also come to the reality that if they follow only one approach, it may be risky for them. Uh, Next is chemotherapy kills more than it cures. That's another myth that we often hear from our patients, because they hear from other patients who might have not survived or some other incidents because of something, and they generalize it for all others. So I think giving the message that some of the doctors also shared in this session, that chemotherapy is more personalized nowadays, and also if we plan properly, target cancer properly, then it can also boost toxicity in many of the cases. So, if doctors' videos, doctors talking about how chemotherapy is personalized and how targeted and different therapies can play a big role in terms of managing the side effects, and also it know more about killing your good cells while it is a very targeted approach, that will empower and educate patients more, because that education is not very readily available. Next is only genetics determine cancer risk. While most of the people don't know that hardly 5 to 10% cancers are genetic cancers, related cancers, right, while all others may be due to lifestyle, diet, environment, and that also plays a bigger role than genetic in many cancers. So again, campaigns from doctors around this will, because I work with patients, doctors both, and mainly if doctors talk about these things, then patients tend to believe it a lot more, and they will go for the screening, and also not having this myth that, oh, it's because of the genetic factors. And lastly, I would say there is a myth that alternative treatment means rejecting modern medicine. While we always talk about integration and not alternative, but always the integration goes together. So, how can we share more data, research papers, and again, doctor videos around integrative oncology effectiveness and how it has helped in patients' better outcomes? So, those are some examples that will really take care of those myths. And especially when doctors, oncologists talk about it, patients really tend to believe it a lot more. So, that will be helpful.
So, moving on with your one of the myths that chemotherapy kills, which is not true. There are certain side effects, but they can be managed, and we have tools to manage. So, I would like to ask Dr. Akanksha, managing treatment side effects is, of course, the key to adherence. And what are some of the latest strategies for mitigating chemotherapy toxicity while maintaining treatment efficacy?
So, the medical advancement has reached to such an extent that nowadays, if a patient is undergoing chemotherapy, we can reduce the side effects up to the tune of by 80 to 90%. For example, now we have antiemetics, that is anti-vomiting medications, because this is the most concerning side effect. We have antiemetics in the form of oral capsules or tablets or injections, which can reduce the nausea and vomiting for the patient. Another thing, to prevent the hair loss, now we have the cool caps available, which we put during the chemotherapy session, and it prevents the hair loss. Another thing is, to prevent the decrease in blood counts, we give the growth factors prophylactically. Also, the diet plays a very important role. And to combat the fatigue, a person should be as active as possible till your body allows during the chemotherapy session, because being physically active will also calm the patient and also help to combat the fatigue. So adherence to doctor's prescription is necessary while undergoing chemotherapy. And now with the latest advancements, we can reduce these side effects till the tune of 80 to 90%.
Right. That's so encouraging. So, my next question goes to Dr. Vaishnavi. Stem cell transplants are critical for certain cancers. What are the biggest challenges in ensuring better access to these therapies for female patients?
So stem cell transplants discussion is always challenging because of the associated treatment-related morbidity and mortality, which patients have to understand, accept, and then go through to get long-term outcomes in certain cancers like myeloma, lymphoma, and certain leukemias. As far as this is a challenge with both men and women, so it's not very specific. But as far as women-centric problems are concerned, I think women, most of the households are the primary caregivers. So this long stay in the hospital and treatment-related morbidity, mortality can be a challenge for women to accept it and also their family. But it's important in the counseling, when we do counseling for these transplants, to impress upon them that this short duration of the discomfort, the side effects, the adverse effects, and the treatment related morbidity, so that can, if they go through this and get a long term outcomes, they can still take care of their family, and lead a meaningful life. So it becomes very important in the initial discussion when we discuss with the family and also the patient. So I think it's more or less similar with men and women. Thank you.
Dr. Namrata, targeted therapies are increasingly replacing chemotherapy. And how do you see, how do they compare, when patient response, safety, and long-term efficacy, they are concerned?
Yeah, targeted therapy is coming a big way since probably last 5-10 years, and because of its inclusion in the government schemes as well. So it's circulating in the society, and many people are, especially in lung cancer, they are using targeted therapy. And toxicity wise, also it's well tolerated. So except for mild toxicity, some skin rashes or some manageable ones, it's very well tolerated, especially in we see as was told earlier, precision medicine is also there. We test for the target, and we give the respective drug, and penetration into the society is also good, well
Right.
accepted.
And we have been talking about artificial intelligence helping us to have, clinical decision making. So, Dr. Nandini, from a clinical perspective, how can AI-driven tools complement oncologists in making early and accurate cancer diagnosis?
So for diagnostics and screening in cancer, I mean, our routine tests, there are guidelines to use them for diagnostics, but AI is going to definitely play a role in terms of, again, like I said, in picking up patterns which a human eye may not pick up. Also, in case of screening in cancers such as lung cancer, where there may be small pulmonary nodules, where you don't know whether it's a malignant nodule versus a benign, and how to follow up these patients. Here, AI tools which are used to probably screen X-rays and CT scans will be useful in developing patterns of which nodules are high risk. We already have radiology criteria where radiologists use certain criteria to follow up these nodules. But again, probably things like artificial intelligence help us refine and help us detect or pick up cancers. Cancers like lung and maybe deep-seated organs are not picked up early because of lack of symptoms when they occur initially. So that is one way which artificial intelligence is going to help us in early diagnosis. And also, of course, the artificial intelligence in the future is going to refine radiology pathology. So patients, when you have anything like a screening or a diagnostic mammogram or a scan, these are going to be able to pick up earlier lesions, smaller lesions, or even predict treatment side effects. So there are studies which look at, for example, we talked about targeted and immunotherapies, and we know a lot of them can cause things like pneumonitis, which is inflammation in the lungs. So people are also looking at using AI to read CT scans of patients before immunotherapy started, to see which patients have lung that will predict factors that are going to predict these, which patients might develop immune mediated side effects. So again, this is how AI is going to help us not just in diagnosis and also in probably monitoring and predicting where patients might develop toxicity. So that is going to come up. These are all in the research phase now. They've not been validated for commercial use, but probably in the next decade these may come out into the market for use.
So from predictive to diagnostic to helping us in clinical decision, right? So Dr. Asma, palliative care is very important, and I believe that it is underutilized in early treatment planning. How can we integrate supportive and palliative care into cancer care pathway to improve the quality of life?
Hi. Actually, the palliative care they have taken in a different way. Only at the end of the treatment, when cancer finishes, like end of the stage when we cannot do anything, then palliative care. People, the normal common man feels that this is the way. Like palliative care comes in the end. It's not that. The palliative care should start with the diagnosis of the disease. When the cancer is diagnosed, the patient should be able to understand what it is, because cancer is entirely a new thing for any person. So, and the cancer word itself makes a lot of fear in a public normal public, so they don't know about it. So most of things start with the diagnosis of the disease, make the patient understand what it is, how we can diagnose it, how we can go through the treatment, what are the effects of the treatment, how she can come out of the disease. So it should start with the first sitting itself. The palliative care person should be involved at the start of the diagnosis, so that patient understand his journey from the diagnosis to the cure or the completion of the treatment. So that should be the first thing to be made to the patient should understand that. The other thing, the other, like managing the side effects of chemotherapy, removing the fear of side effects, financial things, mental tension. See, cancer has many factors which everything should be handled. First thing is the disease, side effects, treatment, cost, mental, psychological burden, financial burden, social burden, professional burden also. Many of the ladies, they want to work because they need a financial support plus the mental support. So once we make them understand, no, you can go ahead with your career, you can go ahead with your work, with chemotherapy, with treatment as well. If we support them in that period, the outcome of the treatment will be good. Patients response to the treatment will be good, and even the it will be easier for the patient to come out of the disease. So this way we can integrate our palliative care at the earliest with the start of the treatment itself, and this misconception should be resolved. And this can we can do it only by making it knowledge, like we should make it awareness should be done regarding the palliative care, and make a platform where we have a support groups to make this understand this palliative care and supportive care, and we have to change this misconception of palliative care.
Right. And immunotherapy has been a game changer. And Dr. Tanvi, how do you see its role evolving in next 5 years, particularly in cancer that affect women?
Right. So, yeah, immunotherapy has been a game changer to say the least. It has helped us across various solid cancers, even hematological cancers. And I already highlighted how immunotherapy works. It basically helps in unmasking the potential of our own immunity and to identify these cancer cells. It helps in preventing the escape mechanisms of these cancer cells, and we are able to target the cancer cell with the help of these immunotherapy drugs. They also don't have side effects similar to chemotherapy, where chemotherapy ends up targeting, the cancer cells. It kills cancer cells, but it also kills normal cells, the fast dividing cells as well, which is why we have so many side effects with chemotherapy. But with immunotherapy, they're mostly immune related kind of side effects. So we know that overall speaking, the usage of immunotherapy has become very popular. It's been gaining a lot of traction because now we have almost a decade of data behind us that shows that there are improved survival outcomes whenever we are offering immunotherapy in combination with chemotherapy or alone. So these are all meant to be complementary approaches and different ways in which we can target the cancer cell and also target the resistance pathways with which the cancer ends up surviving despite chemotherapy. Now, talking about the future of immunotherapy and the current usage also, especially for women-related cancers. So, we know that immunotherapy has shown remarkable outcomes in terms of survival benefits also, both in the curative as well as metastatic setting. And we're able to offer it, especially for a triple negative kind of patients. So, I had mentioned earlier, likely there are hormone positive receptor patients, there can be HER2 positive receptor patients, but then there's an entity called as triple negative patients, which don't have the conventional receptors. So these patients generally had worse outcomes because we didn't have any target to exploit where we could target these cancer cells apart from chemo options. Now we're able to add immunotherapy with our chemo treatment and enhance the survival outcomes and the cancer control rates also. Even in ovarian cancers, we are able to add immunotherapy now with the latest data coming up, where patients, even if they don't carry the BRCA mutations or any target where PARP inhibitors conventionally work, we are able to now combine all these strategies where we are able to add chemotherapy with biologicals, with PARP inhibitors, with immunotherapy, basically a multi-pronged sort of an attack on cancer cells and any possible escape mechanism. So these patients are able to draw benefit from multi-factorial cancer therapies. Then there was something, there's a lot of hype in the media also. Everybody had heard about dostarlimab. So we are able to offer immunotherapies to our patients, even in curative settings like for rectum cancers and GI cancers, basically. So there was an article which caught everybody's attention where there were some 12 patients, they were offered dostarlimab and all the cancer had disappeared and these patients were spared of surgery also. And usually for rectum patients, if it's a low-lying cancer, patients end up getting quite morbid surgeries where the organ cannot be spared also. So these kind of strategies where there is MMR deficiency, although it is very rare in the population, but it must be evaluated in all patients just to see if it is an MMR deficient patient, we are able to give them the benefit of immunotherapy. Immunotherapy works very well in these patients. So slowly we are moving towards where we are able to spare the organ, but at the same time also address the entire cancer from the body. We are able to talk about cure in the realm of cancer treatment thanks to these therapies, and also talking about elderly patients where especially let's say lung cancer patients, if we use the help of PD-L1 marker, as I had mentioned earlier also. So if PD-L1 is more than 50%, these patients can be spared of chemotherapy. Many times we get lung cancer patients advanced stage who are actually not fit for chemo, but we are able to offer immunotherapy for these patients if there are no other driver mutations detected. There's a very systematic and algorithmic approach to cancer treatment now, where immunotherapy has found its space in advanced cancer also and curative setting also. And the future dictates, that the long-term survivors, as we call, like the plateauing of the curves towards the end, as we love to say in oncology terms, those are the true survivors. The long-term responders are the true survivors, where we can even dare to say maybe they are rid of their cancer altogether, even in advanced setting. So immunotherapy is definitely a very exciting evolving space.
Right. So changing algorithms and improving survival. Great, ma'am. Dr. Akanksha, gut microbiota is another exciting, thing which is coming up with growing evidence on the impact of gut microbiome on cancer therapy response. Do you see dietary interventions becoming a standard part of oncology care?
So gut microbiomes, they play a very important role, not only in the cancer prevention, but also when a patient is undergoing chemotherapy or immunotherapy. Why? Because the response depends on the gut microbiomes. A negative microbiome can lead to deteriorated response. Therefore, yes, the standard good diet is the key to it, to have a healthy gut microbiome. What diet we should have? That is the more of the plant-based diet, such as fruits, vegetables, legumes, whole grains, and high fiber diet. And you should always avoid the plant based diet and the red meat. Abstaining from alcohol and smoking is another factor. Another thing which I want to highlight is that nowadays media has shown that if you cut down the sugar, it will lead to killing of the cancer cells. It is absolutely a myth. It does not happen like that. Gut microbiomes do not work like that. Cutting the sugar in non-diabetic patient is not recommended. You should eat a healthy diet, eating more of the plant-based diet, such as the whole fruits, as I've already told. So yes, it plays an important part, and you should take care of your diet.
Right. And Dr. Vaishnavi, I believe that oncology treatment, require collaboration between oncologists, surgeons, radiologists, and genetic counselor. So, how can we optimize it for better patient outcomes? Dr. Vaishnavi. Okay. I think we have lost the signal. So I would like to ask Dr. Namrata, with the rise of at-home care uh, models and digital health tools, how do you see telemedicine and remote monitoring playing a role in long-term cancer management?
Yeah. For palliative patients, stage 4 patients, for them it will be difficult to travel. So we are already doing it in a smaller way. We get WhatsApp reports and we advise and we courier them the medicines. And toxicity also. Sometimes the ECOG performance status for patients unable to walk, they have some toxicity at home. Relatives bring photos, videos to us, and we'll advise them accordingly. So a lot is yet to come. The artificial intelligence based therapies and monitoring of toxicities. I think it has a long way to go.
Right. And Dr. Nandini, healthcare disparities in cancer care access remains a major issue. What policy level changes or healthcare models could help us bridge this gap between urban and rural treatment accessibility?
So, healthcare disparities, we all know, is a big challenge in our country, especially for oncology, where it is a resource intensive branch and a lot of the therapies are expensive. So, healthcare models that, I mean, we do not have universal health coverage like the NHS or Canada, for example, but we know those systems also have their own limitations. We do have a system to provide free healthcare to the poor, but again, it is overburdened. So overall, we spend about 3 to 4% of our GDP on healthcare per se. The government spends, as compared to countries like US and Canada, which spend up to 10 to 15%. So again, that is one thing. Like how much the government itself prioritizes healthcare amongst the expenditure in the country. But having said that, if you look at World Bank data, a lot of patients from in our country spend out of pocket. That means they have to fund their treatment themselves through personal resources, land, whatever, sell their assets. But despite that, we have increased healthcare expenditure. If you look at like based on GDP from 2005 to 20 in the past 15 years, definitely it has gone up. Previously, in terms of USD, the World Bank data said we spent around 700 USD per year of our GDP per capita, and it has gone up to 1900 now. And the government spending also has increased, but the problem is our population also has expanded. So at policy level, I think some things that can be done and are being done in many areas where there is a healthcare disparities, involvement of private or charitable organizations, CSR, where multiple industries or other companies help out by providing donations. And I think this has happened. You can see in Assam, which is like the northeast states, which is, there's a terrain problem, there is a difficulty in access. If you look at 2016 to now, there is a number of cancer centers come up under the Assam Cancer Foundation, which is a collaboration between the Assam government and the Tata Trust, which has helped them. Similarly, in Chhattisgarh and Ranchi and other places, the Tata Trust have helped local centers to come up with oncology facilities and train local physicians. So, in a country like ours, I think universal health model is a dream. It's ideal, but it's not going to happen with a population of 1.4 billion, especially when we have multiple other factors. How much of that resources is going to be allocated to cancer care alone, which may not be an immediate priority, considering we have other issues to deal with, like communicable diseases, tuberculosis, and other factors, and also primary health care, like basic vaccination and care of children and maternal health and those things, which of course take a priority. So I feel at a policy level, more involvement of non-government organizations along with the government. It needs to be a collaboration where they can put in resources in terms of manpower, maybe some technology which can change, like telemedicine, training local like physician assistants or nurse practitioners in areas we know. Like I work in Tata Memorial, where we have patients from interiors of Uttar Pradesh and Bihar, where the nearest health center, forget a oncology center, maybe 200 to 300 kilometers away. So, I mean, we need to work at the ground level to overcome those. And this is where technology, telemedicine, maybe AI, and all these collaborative efforts are going to help. So, at the policy level, of course, the government is making changes. We know Ayushman Bharat is expanded. It's also going to expand its coverage of a lot of cancer therapies from basic chemotherapy. But we know that it doesn't cover targeted therapies, even simple things like EGFR or ALK-based TKIs, which are like, I mean, they transform the patient's life dramatically if you have an ALK positive lung cancer, which is stage 4. So a lot of people are working on it, including what we need is patient advocacy, which is a little behind in our country compared to the West, to push our policy makers to have more equitable, kind of policies for patients. And 60% of our oncology services are in the private sector. Only 40% work in the government sector, and they are overwhelmed. So again, I know again there are many states where they have these health schemes in private hospitals, so that the patients can avail like subsidized or free cancer care at a good center, and private hospitals also collaborate and participate. So this is the way forward. I don't think with the country with our issues and our population, the government is going to fund everybody's oncology care, but I think these are some of the steps we can take, because being exclusively everything that the government does, it's not happening. And I think these kind of initiatives, and I think innovative methods need to be happening for private public collaboration. That is the only way forward, because otherwise, if we want everything to be ideally funded by the government, I think that's a very idealistic thing which may not happen, and it may not help many patients.
Right. And Dr. Azma, we have been talking about artificial intelligence, and Dr. Nandini has told us that it helps us in early diagnosis as well as treatment planning, and there are algorithms. So, I would like to know your perspective on integrating AI-driven decision support system into oncology practice.
So AI has like it's in the new thing in the market now for all the in all the fields. So in oncology also, no, it is gaining a lot of popularity. There are so many projects going on in AI in diagnosing cancer, in making it more accurate and more efficient in treatment. But as we know, AI is like it's a machine, so it cannot replace an oncologist. Expertise of an oncologist cannot be replaced by AI. So what AI does, AI has like it gives us the evidence. It studies the patterns. It gives us the evidence. It gives us like latest research, what is going on, what are the clinical trials for a particular disease, what is the real world outcomes, patient outcomes. So it studies that and it can guide a oncologist in treatment decision, in diagnosing a patient or in treatment decisions. It may support us in decision making, and even it can help us in uh, uh, like a tailored treatment, personalized treatment. When we have a complicated cancers like sarcomas, like who are failed on multiple lines, different cancers which are unable to be like they're not easy to handle. In such cases, AI help gives us the data, many of the data all over the world, wherever it is going on. So
we can guide our treatment. But one thing is that it should be validated properly and it should be explained in a proper way so that patients' privacy doesn't come into picture, and it should not affect the ethics of our duties, whatever we are doing. So this AI has to be validated properly. Yet to come, like in the future, AI will be the big thing. So we have to collaborate with the AI generation people, because it gives lot of like results, like it improves the patient outcomes. That is the new thing to come.
Right. And before I conclude, I would like to take your remarks on that if you could change one thing in current cancer care system, what would that be that would have the biggest impact and why? So I'll start with Dr. Tanvi.
Yeah, so I'll just go back to the first question that you had asked me. There was a thought where, we can actually practice opportunistic screening also. So, there's a long way to go. Of course, screening is not part of our healthcare insurance or protocols. There are still very few people that are truly aware. So I personally feel whenever a patient walks up to us for any n number of reasons, because we have the awareness, we should talk to them about it. Any woman above 40 can be told about the option of mammograms, and any woman above the age of 30 about pap smears, so on and so forth. Opportunistic screening, talk to an elderly patient about colonoscopies and PSA blood tests, things that are easily available to us. So when they come to us for any reason, I think we should also counsel them about a screening option.
Right. And Dimple, what's your take?
Um, I believe early diagnosis, affordable care, and holistic support, it can save lives, improve outcomes, and ensure that every woman gets quality cancer care, no matter where they live. So, working on all these aspects of cancer can really be game changing and transform cancer care altogether.
Right. Dr. Akanksha.
So one thing I would like to change is to break the socio-cultural barriers to improve access to these women for the cancer screening, the cancer healthcare camps, with the pure aim of early detection, because we know that early detection can lead to the highest cure rates.
Right. And Dr. Nandini.
I think two key words, just awareness and access. That is what I wish. I know we can't be very idealistic and want the newest drug for every patient, but the sad part is in our country, even the basics sometimes cannot be accessed. So two things for women especially is awareness. A lot of the time we see that women are diagnosed late, probably present later. There has been a study from AIMS actually which looks at girl child versus boy child, as well as presentations to the hospital, and they find that female children are brought later than the male child because of various socio-cultural reasons. So I think it's very sad that it's happening to us, and probably we are the fortunate women in our country. So my wish for Women's Day and every day for women is to have, one is awareness that there is something that can be diagnosed, detected, and treated, and they reach in time. And of course, access. There should not be any. I mean, the sad part is finances, gender, culture, distance. All these should not be barriers to care for any care. It's maybe cancer or basic health care for women.
Right. I think Dr. Asma, are you there? Wait, he's not there, I believe. Dr. Namrata, I think there is some connectivity issue. I think there are so many takeaway messages from this session, and your insights have really been helpful. I believe our viewers would definitely gain
Hello.
and burst the myth. Yes, please.
Hello.
Yes, Dr. Yes, yes, yes. I can hear you. So, okay, I would like to conclude that we need to bust the myths around cancer, and on this auspicious day, your insights have really been very, useful, and it will definitely help our viewers. Thank you so much for joining us.
Thank you.
Thanks a lot.
Thank you.